So thank you very much for coming. As you know, I don't really introduce our guests because the information's in front of you and they're generally well known. So Alan, believe it or not, you're on.
Okay. All right, so the title of my talk is Research a Benefit or a Burden? Those of you who know me will appreciate that's a rhetorical question. I don't purport to directly answer it today. But first, let me just start by thanking Anton. I'm very pleased to be given this opportunity. I think this is the second time that I've given a breakfast with the chiefs. I didn't have time to try to find my notes for what I said last time. It probably doesn't matter. But I'm very pleased to be here. I guess over the course of my career, I've worked in Princess Margaret Hospital, trained there in the 60s and 70s, was on staff there for 11 years, and then went to Sinai, where I was at the Lunenfeld for a long time, and ended up as director, and did some things in between, and then Art Slutsky was kind enough to give me an office here at the Li Ka-shing for a few months before I started at CIFAR. So I think I know the healthcare system in this city, at least from that distorted perspective, pretty well. So what I'd like to talk about today is two things that to me are quite related. The first is where I see healthcare going in terms of research as a driver. So I'm not going to talk about healthcare writ large, but some aspects of it. And to me, related to that is CIFAR, my current, the organization I'm currently associated with. So maybe we'll start with, I only have, now how do I advance this? There we are. Okay, so I understand there's some people from CPAC, the cancer group from across Canada here, so maybe this was sort of appropriate. I think what's happening in cancer is a forerunner of what's going to happen for most diseases. And I think there's really a tsunami wave that is about to hit the health system. The tsunami wave is driven by a couple of things. One is by demographics. We're a rapidly aging population. The second is the tsunami wave of information and communication technologies. I think we're just starting here in this country to see the tip of that iceberg. I think it's going to increase profoundly. And the third, and there's probably a fourth and a fifth, but I'll stop at the third. The third is genomics and the sort of broader laboratory technologies emanating from genomics. So this slide is meant to illustrate a point, which is if you look at cancer, and cancer has tended to be a beachhead disease for other diseases. And by beachhead, I mean it's tended to be at the forefront of the science and its application to health. So today, cancer is largely diagnosed on the basis of anatomical site of origin. You have prostate cancer, or breast cancer, or liver cancer, or a brain tumor, et cetera, et cetera. And not surprisingly. But I think what's becoming increasingly clear as we develop drugs that are based on the genes that are altered in a cancer is that cancers will increasingly be diagnosed and classified or stratified on the basis of what's shown on the right, which is the DNA sequencing slide, on the basis of which genes are altered. Because at the end of the day, that will guide treatment decisions. And so diagnosis differential diagnosis is in fact meant to guide treatment decisions. And so I think we're going to see a very profound shift over the next X years. And I think we're already starting to see that between what happens today and what happens tomorrow. And I think there's implications for the health system that are quite profound. And I said cancer is a beachhead disease, so just to show you the next slide in this series, this was in the New York Times a couple of weeks ago, quote by Tom Insel. Tom is head of the National Institute of Mental Health at the NIH. And he was quoted when the new psychiatry guide was put out. It's put out every X years to update the psychiatry profession on the classification of diseases. He's the director of the relevant institute in the NIH, and he was quoted as saying that it's out of date. That's a pretty strong quote from a pretty responsible person, and the quote is sort of here, and he talks about the fact that psychiatric illnesses will move from being, a diagnosis based on a discussion with a patient and saying you have bipolar disorder, to based on the genes that are altered in their expression or in their sequence in that disease. And there's probably no set of diseases where that sort of progress is needed more than in mental illness, of course. But again, it's not going to stop with cancer or with mental illness, with psychiatric disorders. It's going to continue into dementias. It's going to continue into heart disease, et cetera, et cetera, et cetera. And it's going to have profound effects, as I said, on the health system. If you think about Angelina Jolie's op-ed, again in the New York Times, now 2 weeks ago or last week, we kind of take it, it was made news because of how well it was written and because it's Angelina Jolie. I said Jolie, my son said, no, it's Jolie, so because it was her, and how public she was in announcing to the world that she had had a preventive radical mastectomy based on a DNA sequencing test. So, think about that. And think about it if this was just 10 years ago, how far we've come in cancer that a movie actor can remove her breasts based on a gene test. That is just a sea change in prevention, not treatment, but in prevention of cancer. And she'll probably have her ovaries removed in a few years as well. So again, I think this is the forerunner of a tsunami wave of change that's about to hit the health system. And it's hard to predict. It's dangerous to predict the future. Marshall McLuhan once said, predicting the future is passé. So I won't predict the future. But I think it's fair to say that we can't quite anticipate all the changes that are going to happen based on all this genomics and science that's going on in the labs here in Toronto and around the world. I think we do know, because we're already starting to see it, so I'm not predicting the future, that there will be much more effective drugs developed based on knowing which genes are altered. Again, if I go back to that previous slide, today if you have cancer, and not to belittle what's going on in the clinics today, but I think it is reality, we're doing kind of what was done in the Middle Ages. We make fun of the Middle Ages. When you had an illness, you were bled. And today, if you have cancer, you're given poisons. And it's the best available treatment. And in some cases, those poisons actually work quite well. We have effectively a cure for childhood leukemia, for example, and we prolong life in many diseases. But they are poisons, and no one would say that they are satisfied with the state of cancer treatment today. We're starting to see, again, the tips of an iceberg of new drugs based on which genes are altered. Okay, so Gleevec for CML or gastrointestinal stromal tumors is the beachhead. There are now drugs based on mutations in other genes for melanoma and prostate cancer, and we'll see more of those coming on stream without question in the next 5 to 10 years. And it's all based on knowing the genetics. If you think about mental illness and the treatment of psychiatric diseases or disorders, you multiply that by 10. People with psychiatric disorders are given drugs that are addictive, that are not particularly effective, electroconvulsive therapy, all kinds of things which are medieval in their aura. And again, not to be critical of the medical profession, those are the things that are best available. But as we gain insights into the underpinnings, the molecular underpinnings of disease, it kind of follows that we should be able to develop new drugs or new treatments more broadly, or new ways of preventing disease, going back to Angelina Jolie's case, based on that understanding. It's pretty fundamental, right? I mean, I think we've got into the habit of thinking we don't need to understand the basis of a disease to treat it, because that's the current state. But if you think about your car, nobody would go to a car mechanic if their car broke down if they didn't think they could diagnose and understand what the problem was first. I think it's safe to say that for most diseases, we don't understand what the problem is first, and yet we're trying to treat it. So that's going to change. It's going to change, and it is changing. And I think that's quite profound. I think it has implications for increasing the productivity of the health system. If I measure productivity by cost effectiveness, again, if you think about the cost of treatment and the outcomes of treatment and use that as in your equation, if we actually have effective drugs or ways of preventing disease in the first place by identifying those individuals who are at risk, again, going back to the Jolie example, unquestionably the healthcare system will get more cost effective. But these are disruptive technologies. These are profound changes in how we deal with disease, how we train caregivers, how we train people who can counsel other women who have, or men who have genes that predispose to disease, whether it's cancer or mental illness or you name it. And so again, how we train individuals in the health system is going to change quite profoundly because of this sort of science and the technologies that come with it. These technologies are also disruptive in the sense that they're different technologies. And so there will be startup costs for implementing these changes. For one thing, every hospital is going to need a DNA sequencing machine, or 2 or 3 or 10. The costs are going down, but there are people who need to be trained. There needs to be buying those machines, et cetera, et cetera. And the research that's leading up to it, of course, is very expensive as well. And so I think, you know, here in Toronto, I think we have a great opportunity, given the relative cohesiveness of especially the teaching hospitals affiliated with the University of Toronto, to get our act together to anticipate these changes. And so just to give one example, I was at a meeting of the Gates Foundation 2 days ago, and Susan Desmond-Hellman, who's the chancellor at the University of California, San Francisco, was talking about a precision medicine initiative at UCSF that they're doing. And it's easier because it's a much smaller university and the affiliated hospitals are much fewer. But nevertheless, I think the principles are the same, where they have all come together and have agreed to share this expensive research infrastructure across the research system associated with UCSF. So, for example, there will be one computer database, not for cancer across the hospitals, but for all diseases, because the infrastructure is the same. Similarly, there'll be one DNA sequencing setup, not for cancer, but for all diseases across the UCSF system. So this is an infrastructure platforms that they're developing, and it doesn't stop there, but I'm making the point, where I think we should be asking the same questions. Are there ways not just of saving money, which is part of it, but also being much more effective? Because when you have that kind of scale up of infrastructure, you can be much more innovative. Fundraising becomes much easier. And you can attract a kind of talent that you can't think of attracting if each hospital or each university does it on their own. So I think these are the kinds of issues that we need to be thinking about. You know, again, in cancer, an area that I know probably best, not only is there infrastructure developing across cancer, but of course the fundraising has increasingly been balkanized to be disease specific. We're all running for breast cancer these days, or prostate cancer, you know, et cetera, et cetera. And yet, if cancer diagnosis is going to shift towards which genes are altered. You know, even our fundraising thinking has to be altered, so that we need to think about how do we raise money to develop a drug against the BRCA1 gene mutation, because it's also altered in other cancers because the BRCA1 genes evolved in DNA repair pathways. So, you know, there's a big change coming, which I don't think we sort of talk about enough in the health system. The other change, of course, is that the cost and the size of the infrastructure is changing, as I've just indicated. The size of the teams that are doing this research and applying it to the clinic are changing. You can't do this kind of research without having strong ties to the clinic. Just impossible. And those cities or hospitals or universities that have built those strong bridges are the ones that are going to make the leads. And this is, in a way, for a scientist, a very exciting time, because this is a wonderful opportunity to actually make inroads and new understanding of disease by having those strong links to the clinic, and of attracting young clinicians and young scientists to this endeavor because of these emerging opportunities that I don't think, certainly I never anticipated even when I was at CIHR. I think it's really a sea change that's happening now. So the teams are getting bigger, training has to change. The teams are becoming more international, because just as I said, you can go from having a computer database for not just cancer, but for disease. If you think about it, there's no reason that the database has to be restricted to one city. Computers have, you know, in a sense, infinite size. And so the bigger the sample size, the more effective, the more powerful the statistics, the more useful that database is. So why restrict it to Toronto? Why restrict it to Canadian cities? The expertise that's required is always changing. The cost of DNA sequencing, for example, has come down about 10,000-fold and speed of DNA sequencing in just 5 years. So not twofold or threefold or 100-fold, but 10,000-fold. So when technologies are advancing at that pace, you cannot be an island. You cannot be a silo that's not aware of what's going on elsewhere. You have to be tuned in on a daily basis for what's emerging. Otherwise, you're obsolete. And so the size of the research teams and the clinical endeavors, I think, increasingly are becoming international and interdisciplinary. You can't do this work without really sophisticated computational technology, really sophisticated DNA technology, as well as really sophisticated clinical care, just to name three obvious things. So all of that is, I think, profoundly going to change how we train caregivers, as I've said, how we attract them to the field in the first place, and how we organize our hospitals. I think I said at a conference about a year ago now, most pediatric hospitals about 80 years ago or so, and Shu Li can verify this, were focused on infectious disease in children. That's not the issue in children anymore. It's a completely different set of issues. The number one issue for children in North America is obesity. And that's not a hospitalization issue. That's a preventive medicine issue. And so how do we restructure our health system to deal with that? The same thing is true with the aging population. Until you're in your final stages of dementia, most of that is caregiving at home. And so again, what's the role of the hospital in that? And I say that with someone who's always been associated with a hospital in my professional life. The hospitals are probably the most respected institution in North America. And so hospitals have a huge role to play, I think, because of that respect in transforming themselves to deal with the changing world of healthcare. And we will see, I think, increasingly, because of this genomics, the ability to predict who is at risk before they get disease. Again, Angelina Jolie. What's the role of the hospital in that preventative aspect of healthcare when you can predict who's going to get diabetes or mental illness or breast cancer going forward? So big changes. So when I finished in New York working with the global HIV vaccine enterprise, and I was approached by the board of CIFAR. I'm now shifting subtly into the next part of my talk. I kind of grabbed at it because there was a couple of things about CIFAR that very much attracted me, and I'll speed up a little bit now. One was, it kind of plays on the themes I've just talked about. One was its global nature. I think it's really critical that the best of Canadian science, the best of Canadian research, be attached to the best in the world. And so what CIFAR does is exactly that. That's our job. We bring together about 400 researchers in any possible field of inquiry. About 40% of those fellows are from outside of Canada. They're in over 100 institutions in 16 countries. And one of my missions is to expand that. There's a lot more than 16 countries in the world, and many of those countries are now getting increasingly sophisticated in their research capabilities. China, India stand out, for example. And so that's sort of, and we connect them for a purpose, which is shown in the red, which is to address really complex, important questions important to Canada and to the world. And they range, again, from anything from health issues to issues in economics, sociology, child development, cosmology, and gravity. So very broad reach. We're basically, in brief, a university without walls, where I have, I think, as I've said to David Naylor here at U of T, I have the best faculty in the world. I don't pay anyone's salary. It's a great job. I've now been at CIFAR for just a little over a year. And in that time, I've been talking to a lot of people, listening, seeing how we can maintain that essential vision for CIFAR, which goes back 30 years to when Fraser Mustard was the president, my predecessor. But given the changing context for how research is done and organized globally, so push the refresh button. And so CIFAR 2.0 is essentially a pushing of that refresh button. There are a number of aspects to 2.0. The one I really want to stress today is the first one, which is our global call for ideas. Some of you may have seen the ad in the Globe and Mail the other day. We've been talking about this at universities across Canada. We've had ads in Science and Nature. For the first time in 30 years, first time for CIFAR, we're inviting the research community to come forward with ideas for new programs at CIFAR. It's quite a profound cultural change for us as an organization, and also procedural change in terms of how we bring new ideas into the fold. And so I want to talk a little bit more about that. So we've clustered our 12 existing programs into 4 clusters, going from left to right. Transforming technology, and there's a number of physics-related programs there. Quantum physics, quantum materials, neural computation, and adaptive perception. This is based, that one, I'll just say 2 seconds about that. That's headed by Jeff Hinton here at the University of Toronto. He's quite interested in, when you have your iPhone, when you type in a word, if you use that word a lot, it will complete the word. Half the time it does it right, half the time it does it wrong. It can't complete the sentence. But most of the time, my wife completes my sentences. Half the time she's right, half the time she's wrong. But she does complete the sentence. So what is it going on in her brain that a computer can't even come close to doing? So Jeff has been developing algorithms to try to model the next generation of computers to think like a human brain based on what we know about neurobiology. And what he's been doing with colleagues in that program Google's gotten so interested that they've bought out his company and have bought out him for half his time. But it has implications for healthcare in all kinds of ways that perhaps we can go into later. So that's one. Sustaining the Earth, several programs there, which I won't go into. Building strong societies, particularly strong theme within the CIFAR cluster. Again, I won't go into any detail. And then improving human health. There's 2 programs there, child and brain development. which is led by Marla Sokolowski and Tom Boyce from U of T and UBC, respectively, and Genetic Networks, which is led by Brenda Andrews here at U of T. You can tell almost from the number of programs that our investment in health programs is our smallest investment. It's about 12%, as I'll show you in a moment. So one reason I agreed to do this when Anton asked me was, this is a plug to you. We're having a global call for ideas. I would like to have many more programs in the health area within the CIFAR stable of programs. And there's the 12% in the sort of 1 o'clock clock there. So just a little bit, just to give you a flavor for what we do. What we really do is just bring together very bright people, the best scholars or scientists in the world around a question, and we pay for them to meet twice a year for 5 years renewable. And some of our programs have been going for 15 years. And it's quite remarkable what happens in these programs. I must say I was a bit skeptical myself when I started, but the best programs that we have are ones that are very transdisciplinary, that bring together. So this one, you can see the disciplines there, the bottom left: functional genomics, genetics, computational biophysics, bioinformatics, systems biology approaches, and people working on every conceivable organism, including humans. And they're really addressing one question, which is how do we understand the genetic networks that control our body? So the BRCA1 gene, just to go back to that, is part of a pathway or network that's involved in DNA repair. And these are very complex networks of genes and their protein products that interact with each other in ways that make our body work. We're not just a loose soup of genes and proteins floating around. We actually have, we're organized. We have very sophisticated algorithms to make us work. And so that program is trying to understand those algorithms, those pathways that make us work as sort of coherent organisms. I'll skip this one. We also have put a high priority on young people. I believe strongly, those of you who know me will know this, in the importance of young people in research and as change agents. And so we have a program called the Global Academy, under which we've created a Global Scholars Program this year, which are some of the brightest young postdocs and assistant profs in the world who are attached to one of our 12 programs. And they meet as a group in Banff every year. So we have physicists and geneticists and economists and sociologists all trying to understand each other. It's like a Tower of Babel, but it's really interesting when that happens, when you bring very bright, smart people together to focus on important issues. So the call for ideas, we're hoping to identify, depending on our funding, 2 to 4 potentially new questions. We're really interested in ambitious, fundamental questions of importance, as I've said, that have the potential to transform our thinking and understanding about a problem, and that's of importance to our country and to the world. And we're interested in identifying a core team that are willing to collaborate deeply. Now, everybody says that their institute, university, program at CIFAR is excellent. We really bring together excellent people. There are 14 Nobel laureates associated with our 12 programs. If you're an economist, you'll know what the Clark Prize is. There's about 6 Clark Prize winners in our programs. So these are really outstanding individuals who come together to talk about an important question. And it really is electrifying when you see this very diverse group of people around a question who are trying to understand where each other is coming from. And after 3 or 4 years, they get to know each other, they get to become a global community, and they start to collaborate with each other with people who they never would have met before. And so this is really a powerful, very inexpensive way for positioning Canada at the center of important global conversations. David Brooks, an op-ed writer at the New York Times, Anne-Marie Slaughter, who now writes op-eds. Some of you may have seen some of hers in the Globe and Mail. She was Hillary Clinton's policy advisor and is now back at Princeton. Anne-Marie Slaughter has written books about the importance of interconnectivity and how the United States will always be the most important country in the world because it has the best connectivity to the best minds in the world because of its universities. So, you know, if that thinking has any validity, I think what CIFAR is doing as a Canadian institution of bringing together the very smartest people in the world around important questions is a great way of positioning Canada in these important conversations. So I'll go from Canada and I'll end with a little bit with Toronto. If you leave aside the nonsense that's going on at City Hall these days, and maybe in Ottawa too, and go to real issues, you know, Toronto is one of, if not the most culturally diverse, ethnically diverse city in the world. Great university, great hospitals associated with that university, very livable city. I really do think that Toronto has the opportunity to position itself at the very center of these very profound changes that are happening, driven by this tsunami wave, as I said at the beginning of my talk, of science and technologies. And how we handle that, how we organize ourselves to take advantage of it, to be at the fronting, leading edge of that, I think is up to the leadership, up to the chiefs, up to all of us, up to you. But I do think that, you know, as a way of attracting bright people to this city, it's, in a sense, easy to do. At the Gates Foundation meeting I was just at, one of the people on the advisory board, the new member, is a guy called Zulfi Bhutan. Zulfi is from Pakistan at the Aga Khan University, one of the world's leading experts on mother and child health. Zulfi's coming to SickKids, to a senior chair at SickKids on global health. So I didn't know that. So he came up to me and told me that 2 days ago. I was very pleased to hear that. And it does, I think, speak to our convening power, our drawing power, to recruit really the top people in the world to position ourselves. But I think it requires us to, A, think big, B, to think together, think collectively. I don't think that any one institution in this city can go it alone. That's nonsense. It's just not the way the world is going. And I think that we need to be attracting the very best people to help realize those visions. So, Anton, I think I'll stop there. I know I've gone a little bit over.
There is an increasing emphasis on intercollaborative practice and interprofessional education. So I see CIFAR with the emphasis of interacting with professionals or experts. But what of the link, say, with experts to the community? I know there's an increasing emphasis on, for example, community-based participatory research.
Yeah.
Do you see CIFAR or other initiatives building better links to do that?
Yeah, it's a great question. So one of the, I didn't go into it, but part of CIFAR 2.0 is what we're calling turning research into action. And again, CIFAR's history, going back to Fraser Mustard, the first work that was done on population health at CIFAR, CIAR in those days, and on child development, really prompted Fraser to start banging on the doors at Queen's Park to have all-day kindergartens. We now have all-day kindergartens because of Fraser Mustard, not just in Ontario, but in several other places in Canada and around the world. So to me, that's a paradigm of what CIFAR should be doing, which is not just what he did, which is taking great insights and knocking on doors, but as you said, engaging the people who could use that new knowledge. So I'm very familiar with that challenge. The first new program I started when I was at CIHR was what we call CARS, which stands for the Community Alliances for Health Research, where we really were putting money on the table to get researchers and community groups to start working together. So I think it's best done actually not at the funding level or at the organizational level where I'm working, but actually at the institutional level where all of you are working. And I think actually St. Mike's, where we're all sitting right now, is a superb example of that. St. Mike's has made a priority the homeless here in downtown Toronto, and there are many research groups and clinical caregiving groups who are working with social program groups and the homeless to deal with that issue.
Up here, be right there. I'd run, but then I'd trip for sure.
Thank you, Doctor. I'm Marnie Weber from UHN. I have two questions. One is, can you talk about the intersection of commercialization and what that does to the speed of research? Does it slow it down or speed it up? And then my second question is the gene patent dispute that seems to be arising, and what your opinion on perhaps the outcome, but what that might actually bode for your discussion on the importance of genetics.
So I think commercialization it isn't applicable to all areas of research, obviously, but for those areas where it's applicable, it's going back to the first question. If you're developing a new drug based on a new gene that you've identified that predisposes or causes a disease, no academic can move that drug into the clinic. First of all, the cost, the organizational stuff that has to go behind it can actually only be done not even by a little biotech company, but can only be done by big pharma. And so I see commercialization as absolutely essential for certain things involved with research. The increased speed of DNA sequencing, which is key to all of this, was all done in the private sector. So I think the private sector is a key partner in all of this. But, and it speaks to your second question, it has to be done under the right conditions. So Myriad Genetics, the company you're referring to, has a patent on the BRCA1 and BRCA2 genes. And it's in front of the U.S. Supreme Court at the moment. They're expected to bring down a judgment sometime soon. I don't remember when. The cost of that test is around $4,000. It should be maybe the true cost to the company is probably the order of $50. So there's a big difference between those two. And indeed, for other genes for which there's no patent, the cost of doing those DNA tests are much, much cheaper. So I think there's a problem, which Myriad has not been willing to deal with. I think, I was just reading in the papers the other day, I think there are some precedents for how to deal with that, where society, through our governments, can say to a company, we really need that test. So we are prepared to buy that intellectual property from you and make it available to all companies to exploit. And I'm not getting into the philosophical question of whether any one company should own a human gene. I think that's a longer conversation. But it was a light bulb. Let's take the light bulb as a neutral one. Should anybody own electricity, electrons, going through metal to produce electricity? We actually dealt with that way back, and so I think we're not dealing with it with genes. So I think we need to, as a society, deal with it head on, and the way we're dealing with it now is not working, I think, clearly.
So I'm wondering where you see the role of basic research in all of this. So basic, blue sky, you spoke about the sort of connectivity between researchers and the clinic, which implies a sort of applied research program. I'm wondering where you see basic research fitting into this.
So I've thought about this for a long time. I think the construct of there's basic research and applied research is out of date. And I think we need to move away from thinking that way. And this is, again, a longer conversation. But in the health area, we tend to divide basic versus applied research to some extent on the basis of which organism you're working with. So if you're working with fruit flies, it's basic. If you're working with human, it's applied, even if you're asking the same question. Okay, so that doesn't work for me. I think you can ask as interesting questions in humans to some extent now as we could in mice when I had a lab because of the power of the technologies. So I think you can do a lot of beautiful research in humans now that we couldn't do before. Similarly, I think there's a lot of work going on in worms that is immediately relevant to humans, even though the worm guys would consider it basic research. So for example, worms have a nervous system. Just touch a worm, it'll curl up. That tells you it has a nervous system, right? So identifying the genes, which are very easy to do in a worm that controls the development and functioning of their nervous system, because of Darwin, we have the same genes. And so identifying those genes in worms is immediately translatable to understanding neurological disorders in humans. So is the worm person doing basic or applied research? I think it's a wrong question. To me, the right question is, are they doing good or bad research? So I'd like to sort of change the conversation. And the division between the two really was a new construct that came in after the Second World War, without going into that history. Okay, before that, people didn't really talk about basic versus applied research. So I don't see that anymore as a difference. And in biomedical or health research, I think even more so now, given the technologies. And I think one of the things that's striking is how almost all good research becomes relevant to, say, in our case, human disease or human health at some point or other. So then it's just a question of what's your time tolerance, okay? So I don't like to talk about basic versus applied research anymore. I think it's not a useful construct. The debate that's going on now between the scientific community and Ottawa around basic versus applied research, to me is an example of that it's the wrong conversation. To me, the conversation should be, why is Ottawa funding research that our company should be doing? So that's another, you haven't asked that question, so I won't answer it.
Final question for Alan. So Alan, this is, no, here we go.
Alan, in the Globe and Mail today reports I'm Bob Phillips with the CPAC group here today. The Globe and Mail reported the Science Council report came out a couple of days ago, and the essence of that report is Canada seems to be slipping internationally in the quality of its science. There have been other articles in the newspaper about perhaps Canada doesn't have enough good scientists, we have enough scientists. You travel a lot, seeing international science. What's your perception of this? Is there a problem, and if there is, do you have any suggestions on what we should be doing as a group?
So this is anecdotal. I haven't seen that report, Bob, and I haven't seen the data behind that report. So all I have is anecdote. Anecdotally, what I would say is that Canadian scientists are not engaged as much in international networks as they should be, because I think that's where a lot of the action is today. And so whether it's in high energy physics, the discovery of the boson, where there were some Canadian physicists here at U of T, for example, involved in that, to genomic issues, et cetera, I don't think we're playing as much in that global scale as much as we should be playing. And that's one reason I was interested in the CIFAR sort of model. If you think about our NCE program, our Networks of Centers of Excellence program, that program was modeled after CIFAR, actually, going back about 20 years. And its job, as CIFAR's was 30 years ago, was to bring together Canadian researchers who are separated by 5.5 time zones. And there was a need 30 years ago to do just that. But we've matured as a nation, scientifically certainly, and also the context in which research is done worldwide has changed. So we don't need a NCE, we need a GCE, a Global Centers of Excellence program, and that's CIFAR. Because I don't think we should be having a program anymore that just brings together Canadian researchers. To me, that's out of date. And so the more we have those kind of conversations and money going into it, I think the more we're missing out on opportunities. So if you think about Europe, the EU is putting billions, despite their economic challenges, billions of euros into getting European researchers to collaborate with each other across countries. Now, they're doing that for a political purpose, which is to create sort of one Europe. But nevertheless, the effect of that is that it's sort of commonplace now for Europeans, as you know that from your time in Europe, commonplace for European scientists in one country to collaborate with European scientists in others. Americans, because of the NIH policies, are always collaborating with scientists overseas. So, and we're not part of those conversations as much as we should be. So in that sense, I would say yes, we're slipping. In terms of the data about number of publications, et cetera, I haven't seen the numbers, so I can't comment.
Well, Alan, thank you very much for coming to Breakfast with the Chiefs. This will be up online, and my video guy will tell me, what, about a week? In about a week, and it does get good coverage, even years hence, people watch these videos. So thank you very much for coming to Breakfast with the Chiefs.